The most immediately important question for patients that they're going to ask as they begin to receive these drugs is, what are my expectations for this drug? I think we've proven quite clearly that the overwhelming majority of patients that receive these drugs are going to respond. The question for the patient then becomes, for how long? And again, we're in a situation where we luckily can't answer that question because the drugs have proven effective enough that we haven't been following patients long enough. So the really immediate next question for patients is, how long can I expect to benefit from these agents? And obviously there's going to be a range, but patients want some guidance. And then the next set of questions will be, what happens when my cancer stops responding? And there we have programs like LOXO 195, which offer patients hope for continued benefit. And for those that LOXO 195 can't help because they have mechanisms of resistance that LOXO 195 can't address, and I think we need to be honest that that will happen, then we need to understand why that's happening and what approaches can be used to overcome and prolong benefit in these patients. And then, of course, you can imagine a scenario where there's a drug even after LOXO 195 as a kind of third-generation compound to address the resistance that arises on LOXO 195. But now we're getting a little bit ahead of ourselves. But what I can say is that we've defined this diagnostic entity and we've established an effective treatment paradigm. And I think we're going to continue to try to improve and push out the benefit of this approach in this new diagnostic entity.
The question of whether or not combination therapy is useful for NTRK fusion-positive cancers is a good one. Certainly what we know from many other driver-positive subsets like BRAF V600E mutant melanomas, EGFR, ALK, and ROS1 in lung cancers is that for the latter three, you can use a single agent and get very good responses and durability. That's what we're seeing with larotrectinib and entrectinib. Now it's a little different from BRAF V600Es that where you use a second drug based on the biology of those tumors. If you add a MEK inhibitor to a BRAF inhibitor, you're getting better activity. That doesn't seem to be a need in the NTRK fusion positive space because the response rates are upwards of 75%. But looking forward to the acquired resistance question, there may be cases where combination therapy might need to be utilized for patients' tumors that develop a resistance mechanism that's amenable to a different pill.
I was just at the FDA talking about tumor agnostic approvals and how this all fits in the regulatory framework of, for example, the Orphan Drug Act. And I think what I came out of that is, one is that tumor agnostic from a regulatory standpoint is complex, but what I also came out of that meeting was that the future is bright. I think everybody, both from the FDA to regulators to sponsors, all are moving towards and searching ways to allow for tumor agnostic indications in the future. What's also exciting is I think there are going to be other opportunities outside of NTRK fusion, outside of MSI-high tumors that we still have yet to explore. And there are many new drugs that are now both in clinical trials and about to be developed that may have significant activity across histologies. So it's an exciting time in oncology, and we'll see what the next 10 to 20 years holds.